Thank you. Good evening. Thank you, Nora, for such a wonderful introduction. Even though I don't do this very often, I've always enjoyed it because this audience is very educated and always challenges me with great new questions that really help me in my clinic. So it's a wonderful opportunity for me as well. So I've made this talk somewhat short because I know many of you come here with many questions, and it's actually very nice to have an interaction. So I want to just go over my slides very quickly to provide everyone with a little background about this area so that we can work from the same foundation and be able to have a little discussion. Okay, so first of all, when we talk about the boomer population, it's a population, look, we've made it, we've sent our kids off to school, they're in college, or many of them are probably in their careers. We're kind of probably thinking about retiring, winding down on our careers and enjoying ourselves, right? So at this stage in life, perhaps for many of us, the focus is really on eating better, maybe exercising more now that we have time, sleeping better, your relationship with each other and your friends, picking up the hobbies that you never managed to do all these years. And the focus in healthcare now, as you speak to your primary care doctors, would be really on screening, focusing on screening for breast cancer, colon cancer, your blood pressure, your cholesterol, all those things that you didn't get to do because you were so busy taking care of everybody else. So what's this thing about pelvic health, Well, what's going on here? Okay, so let me talk a little bit about this and provide you some background as to what can happen in the pelvis and what are some of the treatments that we currently have. Okay, so for women, issues related to the pelvis have been oftentimes neglected over the past decades and ever since the last century. People didn't go to the doctors to discuss their problems because culturally we kind of think, well, it's part of getting old. But now we know with science and better research, yes and no, it may not be that. And even if it's getting old, it doesn't mean that there's no solution. In fact, actually, much of my research, the 6 pages or whatever it is on my CV is actually, I have a basic science research lab and I work on stem cell regenerative technologies. And so we are perhaps making tissues that are younger. So this may not hold true for the 21st century. Okay, it's part of being a woman. Yes and no, because yes, most of the burden of pelvic problems is borne by women, but there are men who actually have urinary problems and fecal problems and other things. So we're starting to understand that this is a problem shared by both sexes. And the third thing is that it's normal after childbirth. And here again, I like to contend and kind of dispel the good old dogma of this after childbirth. Childbirth certainly contributes significant to many of the problems, but it's really not the only thing that contributes. So I'm going to begin by kind of focusing on this childbirth and show you why childbirth has been attributed to be the cause of many of these things. So we'll start, actually, by the way, I'm going to be showing some anatomy pictures. I chose things that are more like a cartoon and drawings rather than real photos, because sometimes that can be a little bit distasteful, especially after dinner. So if you feel like this might make you queasy, you might want to close your eyes. But anyway, I'll go forth. So if you look at this picture on the far left, that's normal anatomy. It's a side view of the pelvis. And let me see, do we have a... I guess just use this. Can you guys see this little arrow? Okay, perfect. So this is the abdomen, and back here is the back. And if you look at, just to orient you, this is the pubic bone, the bone behind the pubic hair. And you have the bladder here and the little tubular structure where the urine comes out. And behind that is the vagina. And in lay terms, it's really the birth canal. That's where babies come out. And on top of that is the uterus, where the babies grow. And behind the vaginal opening, of course, you have the anus and the rectum, where the stool comes out. So when we talk about pelvic health, we're talking about this entire area. And you can see that these structures all are very close to each other. So anything that affects one can affect the other. And On top of this, we have all the intestines, and actually the intestines are very dynamic organ. They're always moving, and you might be surprised because the intestines are really quite heavy. Actually, anatomists have actually calculated the weight of the intestines for an average individual. As I'm standing here, my intestines weigh probably about 35 pounds. So that's a lot, for so where's my arrow? So all these organs here have to be able to withstand this 30 plus pound bunch of intestines. And I'm sure many of you remember carrying your babies, a 10-pound baby. If you're holding in your arms, after 5 minutes, you're going to be pretty tired. Or even a gallon of milk, you hold it up, after 10 minutes, you're going to be exhausted and your arms are going to get tired. So this whole area is actually supporting 30 plus pounds of intestines every second that you're standing. So unfortunately, it's not made out of steel. So at some point, it's going to stretch and give. So my point is that it's not just vaginal birth that's causing these kinds of problems. If you are doing a lot of activities where there's a lot of forces that are impinge on this area, or intestines are very heavy because you might be a heavier person than another thinner person, you can eventually develop problems with the pelvic floor as well. So what happens in childbirth? This is a view of the pelvis looking top down. So as the baby's head is coming down into this hole here, this opening, and you can see that all the tissues actually get stretched, and in particular the nerves that actually reside on the near the bone, they are actually not only stretched, but they're also macerated, because you've got the head that's a hard ball, and then you've got the bony pelvis. So all the muscles and ligaments and nerves are in between. So you got two hard things grinding like this during the childbirth that's coming down when the lady is pushing, and sometimes that can be an hour, it could be 3 hours, it could be quite a bit of time. And so after the childbirth, these tissues are damaged. Luckily, most young women have tremendous healing capacity, so most of these tissues heal, but they never heal 100%. So there's always a little bit of damage that's residual. And you can see that if someone goes on to have 2, 3 babies, each time, if you have a little injury that doesn't heal 100%, you're like, first time, your tissues are 95% good. Then the second time, maybe 90%, and third time, so you can see that with successive deliveries, your muscles are not as strong, your nerves are more damaged. And that's why many of the pelvic floor symptoms in women are attributed to childbirth. But the same types of injuries can occur in men and women who don't have children, but it's just a matter of more time, more wear and tear. So what can happen? So when these tissues are damaged and the nerves are damaged, one of the things that can show up is urinary incontinence. And so I'm going to cover a little bit about urinary incontinence and some of the symptoms and some of the general treatments that are offered, so you can have a baseline to add your information to your knowledge to. We can have pelvic organ prolapse. And what we mean by this term is that the organs that reside here that are actually supporting the weight of the intestines actually they give in, and and what happens is that here's a perfect opening. There's nothing to obstruct it. And so they start to fall out of the vaginal opening, the birth canal, because the gates are completely open. And so obviously by gravity, they're going to come out that way. And that's pelvic organ prolapse. One can also get fecal incontinence, because if the tissues around here, let's say, so the head's coming down and here's your rectum, if the muscles around the rectum are destroyed gradually with more wear and tear of aging and activities of daily life, having bowel movements and constipation and things of that sort, you can have leakage of stool, which is a terribly incapacitating situation. there could also be sexual dysfunction because if all these things are acting up, obviously the vagina is not going to behave normally, and so that could spill into sexual dysfunction issues. And also the big thing for women is menopause, and with menopause you have a general depletion of the estrogen hormone in this area, which can increase symptoms for most women. So today, because of lack of time, each of these topics is a gigantic, it would be a subject of a 5-day talk. So I'm going to focus generally on the urinary incontinence and prolapse, and perhaps we have a little time for questions about the fecal incontinence and sexual function. But these are all conditions that we treat in our clinic as urogynecologists. And in fact, Stanford just opened a multidisciplinary center for pelvic health in our Redwood City clinic facility, and it's under my division. And we work with the gastroenterologists, the colorectal surgeons. We're all in one clinic to deal with all these different conditions, pelvic floor issues, as we enter this age group. Okay, so why urinary incontinence? So from this picture, you can see this is just a graphic of all the ligaments that are in this area as we look down into the pelvis. This is the urethra where the urine comes out, and it's nicely supported by lots of ligaments that anchor it to the bone. So as the baby is coming down behind it, so this is the vagina here, sometimes these ligaments get ripped. And so when the ligament gets ripped, the urethra is no longer well supported. And you can imagine that if I coughed, there's a giant pounding force on this, then the urethra, it becomes unstable. And during that time, the muscles that are embedded in this urethra cannot close very well. And that's an opportunity for urine to escape. And this condition is depicted here, so you can see in the side view, the ligament is not supporting this part of the bladder, and when somebody is coughing or bearing down, this part of the urethra actually opens rather than close, and so you have a result is the leakage of urine, and this is what we call stress urinary incontinence. It's the medical term for it. It doesn't mean that it's stressed out from nervousness, but the stress is a rapid staccato force that goes onto the bladder that causes this leakage and hence the stress. There is another condition, another big category of urinary symptoms and incontinence that falls under overactive bladder. Okay. And in this type of symptom, what the patients are experiencing very often is they report having urinary frequency, they have urgency, leakage with urgency, and people are describing they can't make it to the bathroom on time, and oftentimes they're getting up a lot at night to go to the bathroom. This category of symptoms actually is not just unique to women, and this is where I say just because you're a woman that you have these symptoms is no longer correct. Men actually have a lot of overactive bladder. In fact, if you look at the population data, the epidemiologic data, as men and women age, actually after age 50, the prevalence of this overactive bladder symptoms actually is very similar, and they parallel each other, and they go up essentially exponentially with aging. Now, in the previous slide with the stress incontinence, this is primarily about 2/3 of the patients are women because of the vaginal birth issue. But men also get this type of thing because it's usually after they have had prostate surgery. The prostate surgery sometimes can damage this muscle that's here in the urethra, leaving it very, very weak. And so men can have incontinence for the stress incontinence, but because of a different cause. Okay, so what are the causes for these kinds of symptoms that are also quite debilitating? There are many, and this is why there are so many patients with these symptoms. They can be due to repetitive urinary tract infections. People, as people get into their postmenopausal years, frequent bladder infections is a very common thing. So the infection continues to irritate the bladder becomes chronically inflamed, and that causes these kinds of symptoms. There could be bladder stones that could form, very similar to kidney stones, that can cause more infections as well. If you're a caffeine drinker, if you're on diuretics because of high blood pressure or heart disease, you can also end up with these kinds of unintended symptoms. Bladder cancer can be also present with these symptoms. A bunch of different things. And if you notice here, lots of neurological injuries in the baby boomer kind of age group can also inflict bladder symptoms. The reason being is that the bladder actually is controlled by a set of nerves that emanate from the sacral area. And if you suffer from lower back pain due to bulging discs or stenosis, those nerves are a little bit compromised. And so the message that's coming down from your brain, traveling through your vertebrae down into your bladder is a little bit compromised and scrambled. And so because of the bulging disc, and that can make the bladder misbehave. And that's why also people who have a stroke or Alzheimer's, multiple sclerosis, Parkinson's also have these symptoms because that's where the brain is actually affected. There's a center in our brain that actually controls urination. It's a process that's actually finely controlled, and that's why we're able to say to our bladder, well, maybe I should wait until another 5 minutes until I finish this talk before I can go to the bathroom. And I can control that, right? Because my brain is able to do that. So if you have anything that is affecting that, what we call micturition center, or that control for higher in the central control, you're going to have problems with your bladder. You're going to leak urine. And no one really knows the effect of aging, why aging is also a cause. But it's felt that aging actually causes the musculature, the tissues in the area to change in its robustness and quality. So that's, and then we have a whole big category where we really don't know what's causing these symptoms. Okay, so in essence, with all these different types of urinary symptoms and presentation, it's really a complex field. We have simple stress incontinence due to the urethral sphincter, the valve not working, getting weak. We have this overactive bladder category, which we just talked about. And then there's a whole other field of other symptoms that we have not even begun to understand. So this is an area of a lot of research, and NIH is funding a lot of money so that we can try to understand. This whole big area in the light blue encompasses bladder dysfunction related to diabetes, other medical problems that create these kinds of symptoms. So now, the scope of the problem is really quite big. Just to give you guys an idea, so that this is why we're focusing on pelvic health, because it's estimated that roughly 20% of women over 50 have some sort of urinary incontinence issue. And with the aging population, we are estimating about 43 million American women will have more and more issues. It's costing the U.S. Healthcare roughly $60 billion to care for this. And just to give you an idea, relative value, the cost for breast cancer, which includes, surgery, chemotherapy, blah, 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 all sorts of hospitalizations and all this stuff, is about 180 billion. Urinary incontinence is 60 billion, and we're not even talking about cancer. So it's a lot. But very few people actually ultimately end up seeking care because they think, well, I should just live with it. I'm just getting old, I'm a woman, and the whole three dogma things. And there should be no stigma to this because we've looked at young women in college age, and it's the college age kids, 30% of them actually have some level of urinary incontinence. So it's not just something that is for the older people, but it tends to be more severe and more noticeable in the people in their kind of mid 60s to 70s. And then in the nursing home facilities, as you know, many of you are in the sandwich generation. Maybe you have parents that are in nursing homes, and there are a lot of people with incontinence. So it's a condition that crosses in all generations and age groups. Okay. So everybody's getting into this. Adult diaper sales are expected to increase. And in fact, I know that Kimberly Clark and Procter & Gamble are like neck to neck with designing and marketing to middle-aged women, in the baby boomer cohort to try to get this business. And so this is a competitive field and will very well soon dominate the baby diaper field as people are having fewer kids and there's more baby boomers like us. Okay, so what are some of the treatments that we are offering patients? So now, I gave this talk for Nora, I think in 2012, and we actually had half the amount of treatments as we do now. So we are making progress in being able to offer patients help. So this is just to give you an idea, and if you come to visit us at the Redwood City Pelvic Health Center or my clinic at Stanford, we can give you far more details as to your specifics. So behavioral therapy generally works, and actually a lot of people will gain about 50% improvement. So the way to approach these kinds of things is that there's nothing that's like 100% curative. There's not one item. These conditions are created by multiple factors in your pelvis. Childbirth, aging, trauma, surgery, or whatever. So there's not one thing that can solve the problem. It's a multifactorial approach that you have to do, and with each one of them, theoretically, if you say, well, I'm going to gain a 10 to 20% improvement, if I do 3 approaches, that might give me a 60 to 70% improvement in my symptoms, and that might make me feel more happy and more comfortable. So that's the way to look at these conditions. So if you decide to do behavioral therapy, you might get 50% improvement. Pelvic floor exercises and biofeedback can also give you about 70, which is good. And speaking of which, I actually have a handout that has websites for pelvic floor exercises and core strengthening that actually our physical therapist gave me. She uses this for her patients. So you might want to. There's no harm in trying to do some exercises. That's always good. So you can access these, and some of them, if you can't purchase them, I think Nora can help you through the library, and you can view them. Sometimes we fit patients with a small device called pessary. It's a ring-shape non-silicone-based thing that it sits in the vagina that actually provides a little extra support behind the urethra, and that can help you have less leakage. Weight loss is a big one, actually. We didn't know this 10 years ago, but through some very nicely funded, NIH-funded studies where people who had incontinence were actually randomized and tested to lose some weight. We actually confirmed the fact that weight loss can reduce urinary leakage significantly. And it doesn't have to be a giant amount of weight loss, but it can be anywhere. We start seeing the effect after like 10 pounds of weight loss. So this is something that's good all around for most of us. It's good for your heart, good for your knees. So it's a good thing to engage in. And then finally, we can also, for those conditions where the urine leakage is related to the muscle not being strong enough or just thinned out, we can actually inject materials like inert materials into the muscle to bulk it up and help. And that's a very simple procedure that's done in the clinic, and I'll show you with a picture in a little bit. So this is a picture of how pelvic floor exercises really work, okay? So this is kind of a view like this of the bladder and the bony pelvic sidewall. So you have these muscles that are actually basically, they form the bottom of the bowl that hold all these contents in the torso. And so what you're doing with those Kegel exercises is actually strengthening these muscles so that they can actually help close this urethra. It doesn't do anything to the muscle the actual natural muscle that closes. It's assisting on the outside. So it's kind of squeezing that little tube. That little tube actually has muscle that should close on its own, but that one's probably damaged by childbirth or other things. So what you're doing is bulking up the muscles surrounding it so that it can squeeze when you are coughing or exercising, so that it can assist that weakened sphincter. Now, this is the therapy that I was talking about where, so this is the urethra. If I put a camera in that little tube, I see it open like this because the muscle is not able to close. It should be closing, but it doesn't do it. So what do? I can go in with a little camera, and with a little needle, I can inject this material into the muscle here so that I can close this opening a little bit, and that's how that technique works. It's pretty old technique. It was described in 1938, but we have had many different types of materials. Now we use a synthetic calcium that is very safe and neutral. And there are more different materials that are coming up that take longer time to dissolve. So this is a good therapy. It's quick and easy and safe, but it does wear off, and you have to keep getting injected. Now, for those who are more active or who just don't want to be coming to the clinic and seeing me all the time and getting more injections, there's always the surgery. And the surgery for incontinence is really this sling procedure where we take a little strip of material and we wrap it around us. You can see how that could tighten it, right? And it works very well. It was designed, introduced in the late 1995, and its efficacy is about 80 to 90%. So that means that 80 to 90% of the people I operate on and do this procedure, they've seen a significant improvement in their incontinence, and it works very well. So now let me switch gears over. So what I just talked about, those treatments are primarily for stress incontinence. For overactive bladder, which is those symptoms of urgency, leakage, can't get to the bathroom on time, how do we deal with those? Now, if you have a stroke that caused those symptoms, obviously you would take care of the stroke and treat the primary thing. But a lot of patients actually have these symptoms and we can't identify anything significant. So we embark on treatment that can actually improve their symptoms. It's not really trying to treat the cause because we can't identify the cause. And it's very similar to high blood pressure. High blood pressure is something that we all know a lot about, but we don't really know. Because if we really knew what caused the high blood pressure, we would have a pill to take care of it and eradicate it. But no, what do? We give you blood pressure medications and we give you diuretics, and you're supposed to take it for life. The reason for that is that we don't know what causes the high blood pressure. We can only make the blood pressure go down. We cannot get rid of it. So the same thing here. Now, why do we want to treat overactive bladder? Because we know actually from decades of data that it's has a high impact on people's lives, because if you're just leaking and wearing these diapers, you're going to be having some physical limitations. You're not going to be comfortable being intimate with your partner. You're absent from work a lot. You're going to the bathroom all the time, so decreased productivity. You're soiling your bed linens, and you're constantly washing. So, and socially, you don't want to go out anymore because you're smelling like urine. You're worried about embarrassment. So all sorts of things, it really cause a lot of depression. So it's important actually to treat this and be aware that you can treat it. So, if you have friends that are developing this and you see that they're a little bit isolated, maybe it's a good thing to kind of talk to them about it. So again, kind of behavioral conservative treatment is a big component of the treatment kind of plan. Here we actually, instead of doing the Kegels, we actually do something different. We actually do biofeedback rather than exercises. So this is more like what I talked about with the bulging disc and the Parkinson's. So we want to use the kind of the nerve control to control the bladder. So we have physical therapists do biofeedback therapy, which is a little bit different than pelvic floor muscle exercises. we do time voiding and change in diets, because there are some things in the diet that could be irritants. Caffeine and alcohol are the big ones that we know of, but there are certain dietary components like citrus fruits and things like that that we can help people nail down and avoid. So beyond those simple measures, we're talking about medications for this, okay? So medications really are somewhat effective. I can't say that they're all that effective, so I don't want to give people exaggerated expectations. So they come in two different groups. The traditional ones are the anticholinergic medications. They're about 70% effective. They're responders and non-responders. If you're a responder, you're going to do very, very well with these medications. But I would say there's 2/3 or 40% of people are not going to be responders. But they do have side effects, and sometimes very debilitating and uncomfortable. They are causing constipation, dry mouth, dry eyes, sometimes some cognitive impairment. So they're not really good for people who are having concerns about dementia or who already feel that their memory is a little bit faulty. And for those of you who have older parents that you're caring for, in the last couple years, we've found that they are associated with increased risk for cognitive impairment and dementia for those people who have been using it for a long time. So something to watch out for. There's going to be more literature that's going to come out through the next couple of years, because we're looking into this, because this is a drug that's been marketed heavily, and people are using it without really understanding the long-term effects in the older population. The new group is the beta agonist, and that's really too new for us to have long-term data. This beta agonist seems to have less side effects than the anticholinergics, but it can cause a little increase in your blood pressure. So if you have high blood pressure that's very erratic, this might not be the drug. So these are some of the medications that your doctor might prescribe you on. Even many of the primary care physicians do this already. Okay, so other than medications, since I already told you they don't work very well, gosh, what do we do? Okay, so the new technology, the new treatment on the block is Botox injections. So you're not going to have any wrinkles in your bladder, okay? So, and it works the same way, because the reason why it's used for wrinkles, right? The reason why it works is because when your facial muscles tighten, your skin that's on the surface will wrinkle. So if I go and inject the facial muscle with a Botox, and which makes it relax, my skin on the surface is not going to wrinkle up, right? So same principle here. If the bladder is getting overactive, then we can inject Botox into the bladder muscle, and then it should have no wrinkles, and it should be relaxed, right? So it's a nice, actually, it's a very fairly effective treatment. It's actually more efficacious than the medications, with fewer day-to-day side effects. It's done in the clinic. We kind of don't even have to anesthetize the patient. We put in the scope and we just do the injections. It's not permanent, just like the cosmetic thing. Sometimes in some people it lasts about only 6 months or so. Others people it can go all the way up to 12 months. So it's a once-a-year injection, which is nice. The only major issue is really in some of the patients. The first couple weeks, the Botox strength may be too strong, and that it just means that it will paralyze the bladder too much, so that patients can't urinate efficiently. You can't squeeze all the urine out. So sometimes people have to recur to catheterizing themselves to kind of allow them to empty some of that urine. It's not common, but it does happen. So that's the only downside. Now, another big category of treatment, because we believe that a lot of these overactive symptoms are related to neurological issues, is actually these neurostimulation therapies. So you can see here, we're trying to manipulate the nerves so that it can help control the bladder. So if somebody has, let's say, a problem further off, like they have injury to the spinal cord or something, we can actually put in a pacemaker, and with a electrode going all the way to the sacral nerves. And that pacemaker is permanently delivering a signal, an electrical signal, through the cord down to the pelvic nerves, and then stimulating the bladder. This works about 70% of the time. And but this is fairly invasive. You got a pacemaker involved, just similar to the heart pacemaker. It's the exact same model, same company that makes it. But it's a little bit. A lot of people are not comfortable with the idea of an implant. So we have also this one that's piggybacking on the acupuncture idea, where we put a little needle in the nerve here, send the electricity through this little device, and the electricity is actually traveling up the nerve, going to the pelvis, and pretty much doing the same thing. And this is actually an exciting area of product development, because we have the clinical trials that show that this works. But right now, what happens is that the patient has to come into the clinic to get this done. 30 minutes every once a week, it's really difficult. But I would venture to say, and even now, there's clinical trials done on little devices, home devices that people can actually use. And I think probably in the next 3 years, we're going to see a ton of them on the market, where you would be able to, or the doctor can prescribe you one of these devices. You could buy it and do it at home. And they're usually like a little pad that does electrical stimulation on your foot, or some of these are like little implants that are permanent that we would change in the clinic. So those products are coming. So I'm really very hopeful, because those will provide the stimulation constantly, just similar to the heart pacemaker device, but they wouldn't be so invasive. So that's something to look forward to. All right. So now let me shift gears a little bit to pelvic organ prolapse, and just give you a little background on that as well. So pelvic organ prolapse and any condition that is from the pelvis will be affecting the other organs, because they are so close, and they're generally innervated by essentially nerves that travel next to each other. So if one thing is having trouble, the other one is going to sense it. So all these things very often come in parallel. So when we treat one condition, we really have to keep in mind all the other organs, so that we're not causing untoward damage to the other organs. And if there's a problem with the other organ, we need to treat it simultaneously. So that's one message I really like to leave you guys. If you have any of these problems, and you seek the advice of an expert, make sure that they're actually evaluating your whole pelvis together, and making sure that they're addressing each of these compartments, because you don't want to fix one part and cause the other part to be in trouble, or neglect the other part and not deal with it. Okay, so pelvic organ prolapse actually comes with incontinence frequently, and it's estimated that these problems kind of increase with age, and oftentimes people end up with surgery. About 1/10 of women will undergo surgery. And if you take a look at this, it's really kind of not very good, because these 10% of women that actually go for surgery, about 1/3 of them will actually need a second surgery in their lifetime. Okay, that's the most important thing to remember. So this means to me, what I've actually been professing in my career to patients is that, don't jump into surgery if there are other options, because, and don't get me wrong, I'm a surgeon. I love to operate. That's my thing, but it has to be for the right reasons, okay? If you go into surgery for prematurely, you will have a 30% chance of needing another surgery in your lifetime. And that, if you think about this, if you jump into surgery prematurely and you're 50, okay, you get your surgery, then in 10 years, you got that 30%, you're going to have a surgery. Now you're 70 years old. Now you're 60-something, right? And then you have a surgery. Most American women, American people are living well into their late 80s, early 90s, mid-90s these days. So that means, okay, you're 65, you had your second surgery, then another 10 years later, you're going to need another surgery. and you're now 75 and your medical condition is not as good as when you were 50, and then when you're 85 you're going to need, so now you're like 4 surgeries, and each time you're getting older and each time you're taking more and more risks. So that overall is really not a good situation for anyone. It's setting you up for lots of medical complications. So I always feel that, it's best to just really evaluate the situation, see what we can do, and if we can try to overall in your lifetime minimize the number of surgeries that you're going to have, that should decrease your overall risk from having any medical harm, okay? Now, when you have prolapse, you can have different areas of prolapse, and I'll show you in a picture in a little bit, so we don't want to focus on these things too much. Again, with prolapse, same situation. Very few people seek care because maybe they think they can't be helped. And the cost, again, is very expensive. So this is a picture of how frequently people need surgery. You can see as you get older, as we all get older, the more chance of surgery because the prolapse gets more severe. So what are the causes? It's very similar. Again, the same theme. We got the delivery that's causing the damage, age that's causing the tissues to be different. Weight is a big one. Hysterectomy, if you have a hysterectomy at an early age, meaning before age 40, that can damage the tissues there, similar to a vaginal delivery. So that can set you up for prolapse. And any other surgeries, too, can continue to. Every time you have a surgery, it's helping you, but by definition, it's destroying other tissue. Because I have to go in there, I have to cut all sorts of healthy tissue in order to get to the area of disease to deal with it. So in the meantime, I've already damaged all the healthy tissues too, right? I've treated the disease problem, but I've also damaged the surrounding healthy tissue. So every time you have surgery, by definition, there's been some destruction. And the reason why we do surgery is that the good outweighs this little bit of destruction. So it's always a balance. We're not as good as nature or God's work. And then race is actually interesting. This is probably a genetic issue because we do probably our genes allow us to have stronger ligaments than others. For prolapse, actually, we see that there's very high incidence in fair-skinned people, like Scandinavians, Irish people. There's very, very high incidence, whereas African Americans and Africans almost never have that. I can say this because in my 20 plus years of practicing and being a surgeon for this, I've only had a handful of African American people with this problem. And it's interesting when I ask them, well, are you really 100% African American, like African? They say, most of them actually tell me, all of them have said, oh, well, I'm half Native American or half Asian, Indian. So there's some Asian kind of other race in composition in them. Okay, so the goal of therapy for pelvic organ prolapse, just like for incontinence, it should be primarily relief of the symptoms, okay? These pelvic conditions, the good thing is that they're not cancer. None of them are going to kill you, so you should not engage in a surgery or a therapy that will kill you, that could potentially kill you. You should make sure that it's going to achieve this one goal of relieving your symptoms, because that's why you're seeking care, because you're bothered by it. You can't sleep, you can't be comfortable. So you should make sure your doctor understands that you want your symptoms getting better. All of this are not really as important, whether you correct the anatomical defects. I mean, you have to do this in order to relieve the symptoms, but this should be the primary goal. This is actually for the doctor the surgeon to help you with. You're not looking at your vagina, so you should be worried about the relief of symptoms. Us surgeons, we're always looking at the vagina, so we take pride in making sure the organs are in the right place. But you just want them to work well and feel good, right? Okay, but it's very important that the surgeon actually understands that you have to, all of these are structures are next to each other. You have to make sure that the surgeon actually is addressing all of them simultaneously and correcting them. And let me show you why. These are pictures of prolapse, of different types of prolapse. Prolapse meaning that things are starting to fall out of the vaginal canal, which is the childbirth, okay? I mean, the birth canal. So you can see that if there's a lot of pressure coming from the abdomen, all these walls are supporting the bladder, and the wall that's supporting the rectum can weaken so that the weight of the bladder and the rectum is too much, and it starts to fall out into the vagina. And likewise, the uterus itself, the ligament that's anchoring the uterus can be lengthened, and so the uterus starts to fall, and with it, it will drag down the bladder and drag down the rectum, because these structures are kind of tethered. You can see they're a little bit glued to the uterus in these spots. So if the uterus comes down, the bladder gets pulled down, and the rectum gets pulled down. And sometimes the uterus can come out completely. Kind of the vaginal canal can invert like a sock inside out. And in that case, that's this area where the bladder is kind of kinked off like this, and same with the rectum. And so when we have these extreme cases, patients are very uncomfortable. You know, it's hard for them to walk because it's like having a bag in between their legs, and it's hard for them to empty their bladder well because the bladder is kind of pulled down, and hard to defecate because the rectum is pulled down. So if we are to do a okay, here's my little thing. If we're going to do a surgical repair on something like this, we have to make sure we take care of the uterus. We have to make sure that the bladder is put back into the right position, and the rectum, so that we can solve all these symptoms in one treatment. I'm not, I don't have time. We should just not talk about that. But anyway, so some of the conservative treatment for prolapse, you can see here, this is a case where the bladder is so heavy that the vaginal wall is not able to support it, so it's falling out through this vaginal space. It's called a cystocele. One very easy way of taking care of this without having surgery is actually this pessary, which is a little rubber device we put in the vagina, and it kind of pushes everything up and supports the bladder back into its semi-normal position. So that's something that we can do very easily. It has no risks, essentially. And they come in, these things come in different shapes, and we kind of can fit it for your vagina, and make sure you know how to use them, and help you care for it and monitor it over time. So it's a very easy thing. With prolapse, unfortunately, we don't have any further conservative treatment options other than physical therapy and these devices. Beyond that, we're talking about surgery. And if you think about it, this is a condition where the things are just kind of falling out. So what we need to do is reconstruct the tissues to anchor it. So it's a very simple concept, you know. If the tire is flat, we replace the tire, right? So here, how are we going to... If the vagina has fallen down, how do we anchor it? So there's different treatments, and now we have to have surgery. So we can actually re-anchor it to the normal ligaments, or we can use another ligament if the normal ligaments are shot. So we can do this surgically, and it works pretty well. And I want you to pay attention in the next couple slides of the cure rates, the success rates. So with those kinds of procedures, the cure rates are generally in the 80–90%, but not really always in the 100%. That's an outlier. So this surgeon was probably overconfident here. But I would tend to believe these numbers because that's what the data is showing time and time again. You know, kind of. So that means that 80+% of the patients are having a good result. Okay. Now, another way to achieve the support is actually to use synthetic material. The previous slide I showed you is using your own ligaments. We can use a synthetic material to line the vagina and make a ligament and anchor it to this normal area where it should be. And the most commonly used material currently is the famous mesh. And I want to talk to you a little bit about the famous mesh. But this kind of procedure actually has been done for over 50, 60 years. I used to do that when I was a resident. So it's nothing new. So here again, it's when the ligaments are bad. So if the ligaments are bad, you're kind of left without many options. You can harvest another ligament from another part of the body, but oftentimes if the patient has genetic issues and the ligaments are bad, if you harvest a ligament from another part, it may have the same problem, and then you're kind of doing more surgery. So sometimes we do have to use a synthetic material. It works well, but you have to, the benefits have to be balanced against the longer operating time, more invasive things, and also the issue of having this foreign material in your body. Even though the mesh is good, and in this case, look at the success rates. So about 70-80%. This one is about 98, 93. So, but people are still having their problems come back. 2% came back, 4%, 11% had incontinence, and so you can see that in spite of using mesh, our success rates are no better than using our own ligaments. So this is why these procedures have to be done very judiciously, and your surgeon needs to inform you and have a discussion with you as to whether you want to incur the extra risk for the extra benefit of more durability when the data looks very similar. Okay, so you've all heard about laparoscopic this and robotic this. What does that mean? Okay, so laparoscopic sacrocolpopexy is essentially doing this, placing this mesh this way, not through the open route where we make an incision, but using laparoscopic instruments. So it's doing the same procedure, but using laparoscopic instruments with small incisions. So the procedure is essentially, you'll end up with the same procedure. The problem is that because you're using very small instruments to achieve that, it takes twice or 3 times the amount of time. So you're on the operating room table longer time. And it's highly dependent on the skill of the surgeon. So many surgeons are not very skilled laparoscopists, and so that can increase the complication rate from using those small instruments and also the surgical time. So if you're going to have that, the benefit is that you don't have a big incision, so it's less painful when you recover, but you have to balance it with the skill of the surgeon and your ability to endure longer anesthesia time, you know. So that is a decision you have to make with your surgeon. And what's the robot about? This actually looks pretty scary. I think it looks like somebody's coming on behind it. But this is how the robot looks like, okay? So what it is essentially a tower with all these arms, articulating arms, and it's putting in these essentially laparoscopic instruments in you. So it's a laparoscopic procedure, but instead of having the surgeon here with his or her own hands manipulating these long instruments, you have the robot doing it, and the remote control is at another station. So the surgeon has these toggles that is manipulating these things to do the exact same thing. So it's just a fancy toy to do the same thing, but it does because it's manipulated by this machinery. It does allow some benefits in that, you know, if you have a surgeon that's got a shaky hand, the shaking is not here, okay? So, no, seriously, so this is actually good for people, for the very fine microsurgery where even no shake can be a problem. But for big surgeries, if you have a little bit of shake, it doesn't matter. But this eliminates the shaky hand issue, and there's other benefits as well. But it is actually a problem. But just like everything, you know, there's also other issues with it. It confers a prolonged surgical time. And also, if you look at this, there's like 5 robot arms. So essentially, the patient's getting like 4 or 5 incisions everywhere. So you can have pain in different spots in the abdomen. So there's trade-offs, and you have to, and the operative time is also a lot longer than the traditional surgery. So you have to kind of have these discussions and really understand what each of the procedures are doing for you, the good and the bad. Now let me, well, God, I have to, in the 5 minutes, I'm just going to go through this quickly. So why is the mesh, the vaginal mesh, such a big issue? I will show you and you can realize. So essentially what the vaginal mesh is trying to reinforce all of those tissues that are weakened by placing mesh so that it can strengthen. So if you look at this, so what you're doing is placing a mesh to anchor there to the ligament. You're placing in the vagina and anchoring, and this is what you end up with. Mesh everywhere. Looking pretty bad, huh? So mesh everywhere, here and there, here and there. So, and if you look at this view, mesh everywhere. So you can see why that could potentially be a problem, right? We're not talking about tiny strip like the sling that I showed you earlier. We're not talking about the one putting it in the vagina. This is covered with mesh. So if you look at their success rate, they're very successful. You know, the 92%, but no better than your native tissue. You're no better than your traditional procedures. But look at the complication rate. There are mesh erosion issues in 7.6, excision, new surgeries to remove the surgery. And in some literature, it can be as high as 17%. So this is why these mesh procedures for prolapse actually got a bad press and had all those lawsuits. To the point where that they came about and they were marketed heavily by the companies in the early 2000s, 2005, mid-2000s. And the complications started, so the FDA issued a safety communication in these years, an update in 2011. Then in 2016, the FDA really upped the ante. They said, well, wait a minute, these procedures are so bad, we have to put them in the, in the high-risk category of devices. And just last week, the FDA made orders to the companies to discontinue these kits completely. So we can no longer do the vaginal meshes anymore. But the sling devices for urinary incontinence, that little sling that I showed you in the earlier picture, that is still actually very good. The risk associated with that is very, very low. And the difference you saw is that we have a tiny, tiny little sliver of mesh versus this thing, when too much of a good thing is bad, right? So that's probably what happened. So I want to leave by a couple of things, okay, to conclude. So these are conditions that are all very common. Probably all of us will have at some point some of these things. So important to talk to your doctor and understand what can be done and what you have to be careful about. You should try conservative therapy, and I would encourage you guys to look at some of these DVDs. So when you do decide to undergo treatment, it should involve an assessment of all the surrounding organs so that everything is taken into consideration. And traditional surgeries are still very effective, but that's not to say that new innovations should not be examined. New innovations have their own qualities. They are less invasive, but they there could be issues, and one should only use them if they've been properly tested, for safety and long-term efficacy. So I'm a big proponent of new innovations. That's why I do my stem cell studies. But my stem cell project is 10 years out. We are funded by the California Institute of Regenerative Medicine for that reason, so that we can do the proper clinical trials that the FDA requires. Very, very important. I think that's really, I have to emphasize that. And this augs.org is the website for American Urogynecology Society, and that's the website that you can get a lot of really great information. Go to the patient service tab, and you'll see a lot of these things. And the publications tab, there's a pelvic floor dialogue. So these are dialogues with that they've written in lay language for patients to understand many of these issues. So this is really a good resource for you guys. And then finally, I like to leave you with this. I like David Bowie, since I'm a baby boomer, that aging is an extraordinary process where you become the person you always should have been. I am grateful for that because I am still trying to be that. So thank you for your attention, and I'm very sorry that I should have spoken faster. So thank you for your attention. That's why I'm clapping.